Thank you for staying with us. We sincerely apologize, but we were unable to connect with Mr. Kubai, so we're moving to the next segment. And we have our guest on standby already, and it has to do with maternal mortality in northeast Nigeria. Now, in the northeast of Nigeria, childbirth is one of the most dangerous journeys a woman can face. Hospitals are either destroyed, too far away, or unsafe to reach because of conflict. Roads are risky, especially at night, and many women are left to deliver at home or in poorly equipped mobile clinics. Now, the result? Tragic, as 1 in every 100 Nigerian women dies in childbirth, with more than 75,000 maternal deaths recorded in 2023 alone. Now, this crisis is made worse by shrinking resources. International donors have pulled back funding, and Nigeria's government slashed its family planning budget by 97% this year. With few doctors, little medicine, and collapsing infrastructure, women are being left behind. So what should be a moment of life and joy has instead become a life or death risk. Let's take a look at this package before we move on to the conversation.
Maternal and neonatal deaths remain a significant global health concern, with disproportionately high rates in low and middle-income countries. This is worsened by conflict and lack of access to quality antenatal, delivery and postnatal care.
Nigeria is one of the countries that has the highest maternal and neonatal mortality rates. In particular, 1 in every 8 minutes, there is a mother that dies because of giving birth. This must be crushed.
The United Nations Children's Fund, alongside Borno State Ministry of Health and Primary Health Care Board, launched the distribution of mama kits to encourage women go for maternal health care services in Borno State.
UNICEF, together with the partners, will provide commodities. We are already providing vaccination support. We are already providing health workers support. We are already providing capacity building for the different units of Ministry of Health. We are already providing also digitalization of the health services in the state.
The state is highly committed, and the executive governor has demonstrated all the political will and the support. As you are aware, he has already surpassed the 15% health financing target by WHO in the state in both the 2024 and 2025 approved budgets. And just yesterday, about 10 ambulances were, commissioned by the coordinating Minister of Health and Social Health, Professor Muhammad Ali Fateh, for the state emergency medical services and ambulance system.
Local health workers and community leaders welcomed the intervention, describing it as a timely and life-saving in rural and IDP hosting communities where maternal health services are still under strain.
We are working with UNICEF and all other our partners to see we have enough number of human resources across all the 13 LGS.
Health officials believe this intervention, accompanied with persuasive drama, among other strategies, will strengthen delivery services in underserved areas and encourage more women to seek skilled birth attendants. In Maiduguri for News Central, Umar Kirawa.
Now joining us to speak more on this, we have Professor Rosemary Ogu. She is National President, Medical Women's Association of Nigeria in Port Harcourt. Thank you so much, Professor Ogu, for joining us at this time.
Pleasure.
Now, they say that Nigeria lost about 75,000 mothers in 2023 alone, not even counting that for 2024 and 2025. In 2023, that would say is more than a quarter of the global total. From your perspective, what exactly is driving this tragedy?
Poverty. 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 Women's inability to take decisions, to take decisions, to pay for services, because in Nigeria we still pay out of pocket. because we have less than 10% of the country under health insurance. And so when the woman is pregnant and has complications, even when government has facilities that women can use and get free care, the women are unable to access the facility. They're unable to reach the facility. So poverty and inability to take decisions, those are the main reasons why our women still die.
Okay. Now, we're told that Dr. Anna Peter, an obstetrician and gynecologist at the University of Maiduguri Teaching Hospital in Borno State, has joined us as well. Thank you so much for joining us, ma'am. I did not hear that. Can you unmute your mic?
Okay.
All right, I can hear you now. I can hear you now. It's fine, ma'am.
Okay.
All right, so you heard that. Professor did say that, poverty is the major culprit. Would love to hear your own thoughts, because we've heard that 1 in every 100 women, actually, or women, dies in childbirth here. And she talked about people, pregnant women being unable to access, some of the facilities that are available due to poverty, even in Nigeria. So what is your take when other countries with fewer resources are even doing better?
Oh, thank you very much for this question, because I think it's very timely in that Borno State and Nigeria at large is having very high maternal mortality. I think one of the reasons why women die, despite the fact that there is poor resources, is that we do not have the healthcare workers that we need to have at the places where we need them. For example, we have women in local government, and we have women giving birth at places where it's very hard to reach. And we do not have skilled healthcare workers in such areas because people do not want to go there for fear of their lives, and usually for poor healthcare facilities there. So I think one of the reasons why women die is we do not have the skilled healthcare workers where women need them. Another reason is that we do not have healthcare resources at the point where women need to utilize them. For example, when a woman comes to the hospital, the things she needs to save her life are not available at the point where she needs to use them. And I think that's one of the reasons, some of the reasons why women die. And apart from poverty, I think illiteracy is one of them. People don't go to the hospital. They'd rather give birth at home for one reason or the other. And I think we need to enlighten women on the need to access healthcare facility and assess the care on the use of healthcare workers in delivery to prevent complications that arise and causes of maternal mortality.
All right. Well, ma'am, you've worked or you're working closely with these women in Borno State, so you're in the right position to actually tell us what giving birth actually looks like for the women there today. But we will find out more on this. We just have to quickly go on a break. When we come back, Professor, we will definitely come back to you as well. Stay with us. Welcome back, and thank you for staying with us. So we're talking about the high death casualties for pregnant women, that's maternal mortality in the northeast part of Nigeria. And we still have our guests, Dr. Anna Peter and Professor Rosemary Ogu, still with us to speak more on this. Now, just before the break, I was actually talking about how you, Dr. Peter, are working closely with some of these women in Borno State, and the Northeast in general. And I would love for you to paint a picture for us, on what giving birth looks like for the woman or for a woman there today.
Okay, so giving birth in Borno State today is quite difficult because we have, like I said earlier, we have women living very far off from the central. Now, Borno State is very big, and before you could travel from places like Mongono, Goza, Biu to the central to access healthcare services, especially when you are being referred, it's very difficult. Sometimes you can get ambushed. Sometimes there could be strikes by insurgency, and then it makes it difficult. Sometimes a woman, before, like from Gomborun Gala, it might take you 2 days for a woman with obstructed labor to get to Maiduguri capital, where she's being referred for a cesarean section and the like. So, like I said earlier on, it's very difficult for her. Before she gets there, sometimes the obstructed labor will have occurred, she will have bled, there will have been PPH and other things that would cause her to die. But like I said earlier on, one thing, since these values from WHO has reached the state, the governor and the government through the Ministry of Health has been doing a lot. They have decided, because I said skilled healthcare workers are not available where they need to be used. So one of the things that the state governor has done, Governor Babagana Umara Zulum, MNI, is to increase the rural posting allowance for midwives and doctors so that they get to stay in such places. And then these hospitals have been equipped with facilities so that when women go to the hospitals, rather than referring them or bringing them to the central, which will take like 2 or 3 days before they access healthcare facilities, the health workers go there. So that's one of the things the government is doing, to send health workers there. And then there's this the ambulance services, emergency services, which was just launched, and I think it's very, very a good initiative by the governor so that women get to. There's no delay of transportation now to bring these women, because before now it's very difficult. I can tell you, sometimes these women come, they have bled, sometimes they come, the babies have died, and sometimes there's sepsis already, and when they reach these facilities, before you start to intervene, the women get to die, and that's what is causing our high rate of maternal mortality. And you know, blood transfusion here is a problem. After PPH, it becomes so much problem because people do not like to donate blood. And so one of the things the state has done is to adopt the E-motive, which is an initiative to begin to assess for blood loss before she begins to bleed. After delivery, when you assess her blood loss and it's above the limit that is acceptable, you initiate this bundle of care. So, but the state government has adopted E-motive, and this is very important. And we know that in some months to come, when we assess the maternal mortality in Borno State, we know it's going to reduce by numbers. So it's very difficult for women before now. But we believe that with the bundle of care that the government is putting in place, in some 6 months to come, when we review the Northeast maternal mortality rate, it will decrease by a significant number.
All right, so let's hear from Professor Ogu as well. Professor, clinically, what are the biggest killers when it comes to maternal mortality? Is it bleeding, infection, eclampsia, unsafe abortion? And which of these are actually preventable right now?
Bleeding is preventable. Bleeding is preventable. Like Anapisa was just talking, if you are able to take charge early, if you're able to make the diagnosis early, then you can save the woman. In the study that was carried out by Galadanchi and team, women who had postpartum hemorrhage, that is bleeding after delivery, women who had diagnosis early, who had treatment early, they didn't die. But if not, the women would die from bleeding. The women may have eclampsia, they are convulsing, and then they get to a facility. There is no magnesium sulfate. Magnesium sulfate is the drug that you would use to treat eclampsia, and it is not available. Or a woman comes with very high blood pressure, and the antihypertensives that you need to treat are not available. So those women would die. So whether from bleeding, whether from eclampsia, whether from infection, sepsis, you know, those women will not survive if they get to a facility and the commodities to use in that facility are not available. And sadly, that is the case in many of our facilities. The commodities are not available. Let's call a spade a spade.
All right, so I would love also for you to speak on, you did hear Dr. Peter, you know, give an idea of what giving birth, you know, in the Northeast and Borno State is like for these women. What do you have to say about, you know, what these women have to go through in order to deliver their babies safely?
The same challenges. A woman is in labor and there's no one to take her to hospital. She cannot afford transport. The means of transportation is not there. The roads are not good. It takes time from when she says, oh, I want to come to hospital to when she gets to hospital. For us, in the Medical Women's Association of Nigeria, there's something that we started recently where we have a WhatsApp group for all our pregnant women. And so when they're at home and they have an issue and they want to come to hospital, they let us know on the WhatsApp group. So we prepare for them before they get to hospital. That way, you're able to shorten the time, the delay in reaching out, in assessing, in providing care for these women. But in scenarios where you don't have that group, where you don't have that means of communication, the woman is in her house and suddenly maybe ruptures membrane, sees water, or starts bleeding. The kind of thing that happened to me when I had my last baby. You know, I went to wee in the bathroom, and the next thing I saw, the whole floor was filled with blood. I was bleeding. The luck I had, the reason I'm still alive today was that there was a vehicle to take me, and as we were on the way, we were calling. So the anesthetists, the obstetricians, everyone, blood bank, hematologists, they were on ground to receive me as soon as I got to the hospital to provide that care. So imagine if I didn't have that network, if I didn't have that ability to make calls, if I didn't have a car to take me to hospital at the time I noticed I was bleeding, I won't be here today talking to you. And so we must make efforts to ensure that women who are pregnant can have access to health facility, transportation, facilities that are ready and waiting to receive them when they get there, facilities that have light, electricity, water, people to do the work, human beings to do the work, not that someone is on call and one person has jackpot, there's only one person, you are attending to so many people, you are not able to give the care because you are under-resourced in terms of manpower, in terms of commodities, in terms of consumables. So the picture for a woman who's pregnant is not a very bright one. There are challenges, and it will be good that government steps up. I know government is doing a lot, but we can do more.
Okay. Now, speaking of government doing a lot, Dr. Peter, I did talk about how some solutions have been put in place for these challenges. Governor Babagana Zulum has actually, made some provisions to make it easier for these women to safely deliver. But then we've seen hospitals burned and clinics destroyed in some of these conflict areas. So in conditions like these, what does emergency care really look like when, even access to transportation is kind of sketchy because you're not sure of the road that you would have to pass to be able to get to the hospital?
Yeah, unfortunately, I would like to give say something good, but I can't on that because it's really very difficult. Prior to now, when the insurgency was at its peak, I can tell you that it was really, really bad. And I think that is one of the things that contributed to the very high rate of maternal mortality. Despite the fact that you would like to do something about it, you can't really do anything about it because there are times when you have healthcare workers being kidnapped and some being killed on the field because they are there to help women that are giving birth. So it's very difficult. I will give you a scenario that on one of such occasions, we had a woman that came to the hospital after running in the bush for several days and came to the hospital with already ruptured uterus. But when I say ruptured uterus, the uterus that had already busted because she tried to labor and the baby is not coming out. Not only had she ruptured, but there were bones already sticking out of her abdomen. It was really a terrible sight for me. And I never forgot that picture. Because shortly after she came, she actually died. This is a woman that has been running in the bush for several days. But for now, things are getting better. We've seen instances where the governor himself has been to such areas and encouraging other health workers to be there. He has renovated these hospitals that were burnt down. He has equipped those hospitals that were burnt down. And now we have midwives that have been employed there. So, and midwives that have been trained under the state, under the basic emergency obstetrics care. So they are able to identify early when there's complications and then they refer. So the state government together with some NGOs are available at the local government area. So we don't really see the gory details we had before. It's getting better, I can say, because these women are referred on time, but still, there's still more to be done. Our hospitals are still not where we want them to be. And a lot of people will talk about healthcare workers, maybe the JAPA syndrome. I think people do not really JAPA because of the money that they are not being paid. It's because they do not have resources, healthcare resources to work with. Imagine you have a woman bleeding, like I said earlier on, and you do not have normal saline, you do not have cannula, you do not have the facilities to use at the point to save her life. You know, you leave that hospital knowing that you will have done something, but these resources are not there. But one of the things that is being done in the state is to offer free medical services. I mean, when you go to the hospitals, sometimes for cesarean section is free, and I think that's one of the reasons why a lot of women are accessing the state hospitals in our state now, because it's free, and then these resources are available. And one of the things the state governor has done is to bring drug revolving, to the state drug revolving fund, meaning that there are drugs available for women to use, and especially the magnesium sulfate we're talking about, the oxytocin we're talking about. And I know that the presence of M1 in the States and the research done by Professor Galadanti has reinforced the use of the emotive, meaning that the oxytocin, the misoprostol, the tranexamic acid is available for use to prevent PPH, which is one of the killers of our women after delivery and even in pregnancy. Thank
now,
you.
coming back to you, Professor Ogu. Now, some areas, rely on mobile clinics, just as she has said, instead of hospitals. Now, in your professional view, can these clinics, these mobile clinics, can they safely deliver babies?
Yes, they can. The mobile clinics, the mobile boats, in the riverine areas, yes, they can. And we're going a step further. We're doing telemedicine now, and we're using telemedicine with mobile clinics. You can have different clinics and at the point. Although some people will say this is highfalutin, but it's possible. In areas where you don't have enough manpower, where you don't have enough human resources for health, we can use mobile clinics to fill the gap.
This crisis, comes down to insecurity. That is, women simply unable to reach a health worker versus lack of trained staff or even supplies when they do get there. Professor?
Sorry, come again.
I asked how much of the crisis, right now comes down to insecurity. Is it the women that are simply unable to reach a health worker, or is it the lack of trained staff, or is it supplies, when they do get there, supplies that are unavailable?
It's all of them. It's all of them. I don't know if we can single out one and say this is the main problem. But the insecurity in terms of I'm afraid to go out, I can't come out, it's one. The insecurity, I get to the facility and they don't have supplies. The insecurity, I get to a facility and there are no health workers, or the health workers are tired and they're not giving their best. So all these are issues and they must be looked into.
Okay. Now, we also know that Nigeria has cut its family planning budget, by 97% this year. As a health expert, Professor, what consequences do you expect from that cut?
Oh my goodness, it's going to be terrible. Because without family planning, you're going to have so many women getting pregnant. So many women getting pregnant. And then for those who may have the wherewithal, they want to now discard that pregnancy. So the rates of abortions are going to go up. And then for those who maybe for moral reasons, for reason of, I don't want to tamper with the pregnancy I already have, they're going to end up with maternal mortality. They're going to die because they got pregnant. And they could have been saved if they didn't get pregnant. So cutting down family planning funds, not paying attention to family planning, not paying attention to the primary prevention of maternal mortality, which is contraception and family planning. I don't know where we're going. I don't know how we're going to cope. I don't know how it's going to be, but the future doesn't look bright. It doesn't look bright. Family planning funds slumping. Yes, we know the funds, the aid has gone up. USAID is no longer there. All those giving funding for family planning, a lot of them they've gone. But what about us, our government, ourselves? We should stand up and take care of ourselves. Stop depending on donor funding.
Now, coming back to you, Dr. Peter, we're still on this, towing this line of, donor funding, which has actually dropped significantly and sharply at the same time. What gaps has that created on the ground for you and your colleagues?
Okay, so now I will start with the family planning that Professor had already started talking about. Now, without family planning, now, not only are we going to have abortions, these abortions are going to be unsafe. Now, this family planning, not only, it helps us when people come for emergency contraceptives. So they are part of the things we give. You see, it goes down. There are people that have been raped or sexually assaulted that come to the sexual assault referral center, which we need to give emergency contraceptives to. These things are not available. Now we would have teenage girls, people that are not ready to get pregnant, getting pregnant. So you can imagine the catastrophe this will cause. Now, apart from that, you are having women that need to space. Like you have women that have had 10 children. They do not want anyone again. And, the situation is very hard. Now, these things are not available. Now, one of the things that we are seeing with this court is not only in terms of family planning. Now, antiretroviral drugs for prevention of mother-to-child transmission of HIV would go up because antiretrovirals will not be available because of this cut, and women will not access antiretrovirals. And then now there will be transmission of HIV from mother to child, and then you see infections will go up. So this funding, as we can see, and with this cut, in my state, we can see a lot of people that were in jobs were out of jobs. So one thing will lead to another. Poverty will increase. People are unable to access healthcare because we do out-of-pocket funding. And so, like I said, the government will have to step in big time. They have to step in and fill in the gap. We cannot keep depending on donor funding for our healthcare. These are things that we need to sit and reassess and increase the funding, increase the budget for health so that people can accept health. Family planning is a right, is a reproductive health right of all men to access a family planning of her choice. But if she cannot, then we can see that people wouldn't go for that, and then more complications will be, we'll see more complications, like Professor Ogu has said earlier on.
Now, speaking of complications, while we plan on wrapping up, Professor, beyond childbirth, what about aftercare? Would you say that mothers are getting the support for complications, or are most of them left to struggle on their own?
Care after childbirth has never been a big thing for medical practice. We've always had low postnatal care coverage. So when women deliver, they don't usually get the care they need. Some do, but not as much as we want. As an obstetrician gynecologist, one of the key areas where we always advocate for more women to try and use the service is postnatal care. That is the care received after childbirth. Now, to make it easier, at the primary healthcare level, they're supposed to have volunteers, healthcare workers who go into the communities to look after women who are just delivered on day 1, on day 3, day 5, day 7, and day 28, But you would see those same cadre of staff tell you, oh, I do not have the means to go to the community. I do not have the means to go the house to house. Oh, I don't have any transport stipend. Oh, we don't have any funds. Oh, we don't have vehicles. For those who have vehicles, oh, we don't have fuel. So we're not doing enough. We're not doing enough, and we can do more. We can't do more. We can't provide postnatal care for our women who have delivered. The number of babies who die within the first 1 month of life is astonishing. It's a lot. And if you can take care of that first month of life, then you would massively reduce the number of children who die under 5 years of age, under 1 year of age. So we can do more. And I'm happy that you brought up this question, and I hope that for those who are listening and those who have the ability to do something, that something can be done to improve maternal health care during, before, and after childbirth. Thank you.
Thank you so much, ladies, for taking time out of your busy schedule to speak to us on this. We really appreciate you for your expert view. Dr. Anna Peter, obstetrician and gynecologist, University of Maiduguri Teaching Hospital in Borno State. And we also had Professor Rosemary Ogu, National President, Medical Women's Association of Nigeria in Port Harcourt. Thank you so much once again.
Thank you.
Thank you for the conversation. It's a pleasure.